Hello, I'm Dr. Aishwarya. I'm a consultant gynecologist and fertility specialist practicing in Chennai. Today I'm going to deal with a topic which is very useful for all the people who are either undergraduates or postgraduates or practicing gynecologists also. It's ectopic pregnancy and the recent updates. So why I chose this topic as the first topic in my series of presentation is because of its importance, and the understanding of the topic is slightly less in when we start our career. However, after practicing fertility for some years, we have seen for ectopic pregnancies of various types, and we have used various modalities of management. So I also want to give the practical inputs in this presentation. So let us go to the presentation. So the outline of the presentation will be introduction, classification, epidemiology, etiopathogenesis and risk factors, diagnosis, differentials, management, reproductive outcomes, the non-tubal ectopic pregnancies, and the final take-home message. Incidence of ectopic pregnancies. So according to the Green Top guidelines, it is actually 2 to 3% of all the pregnancies. So when it's only 2 to 3%, why is it so important? Because women still die of ectopics despite the growing investigations, despite the availability of investigations, and also the complications sometimes are mismanaged because of the knowledge amongst the gynecologists is slightly less while trying to investigate the disease. So the definition according to the books is implantation of the products of conceptions at sites other than the endometrial cavity. So what we can see is actually, so this is whatever is implanted inside the uterus is called as the intrauterine pregnancy, and any pregnancy that is lying outside the uterus according to the books is actually the ectopic pregnancies. There is also a term called as eccentric pregnancies, which I would be dealing in the further course of the presentation. So this 2 to 3% of the pregnancies can lie anywhere. So it can be the most common is actually the tubal pregnancy, which is actually 90%. Then in the tubal pregnancies we have various types, and the most common in the tubal pregnancies is the ampullary ectopic pregnancy. So we all know what is the tube, what are the parts of the fallopian tube. One is the interstitial part, then the isthmus, then the ampulla and the fimbria. So the most common is actually the ampulla, where the fertilization actually occurs. Thereafter it is the isthmic part and then the interstitial ectopics. And as far as the non-tubal ectopics are concerned, our idea is slightly less. However, we do see it especially when we are practicing fertility. So the non-tubal ectopics are the ovarian ectopic, the caesarean scar ectopics, the cervical ectopic and the abdominal ectopics. Ovarian, yes, we do see rarely. Caesarean scar is actually rising because of the increased rates of caesarean section, and also we are able to diagnose whatever was diagnosed as cervical pregnancy initially would have actually been a caesarean scar pregnancy. So because of the improved diagnosis, we are able to diagnose. Abdominal is definitely one of the most fatal ectopic pregnancies which is there. Yeah. So then risk factors as far as ectopic pregnancies are actually Afro-Americans. The race itself, there is an increased incidence of ectopic pregnancies. We have seen several Afro-Americans who had been with us where I did my post-graduation, All India Institute, Delhi. So we have seen lot of Afro-Americans coming to us with ectopic pregnancies, and it was slightly higher when compared to our Indian population. This is as far as spontaneous ectopics are concerned. However, there is an iatrogenic risk of ectopic pregnancy, that is by means of increased IVF conceptions. That is what is my field of specialization. So we do see a lot of these ectopic pregnancies in our practice. So the first thing which we rule out in any IVF conception for that matter is whether it's an intrauterine or ectopic gestation. Then pelvic infections, presence of an copper-T, increased rates of detection, as I told you, because of the increased availability of ultrasound and the rising number of cesarean that is causing the cesarean scar pregnancies. And ruptured ectopics are actually 2.7% of all the pregnancy related deaths. That's still a high number, considering the increased availability of diagnosis and also the skills and the expertise. Though the classical factors which usually people are taught in the post graduation is PID, chronic salpingitis, chronic inflammation or distortion of the tubes, fibrosis, tubal occlusion, and the important causes of this tubal pathologies are recurrent PIDs. Genital tuberculosis, as far as India is concerned, is still the #1 cause of tubal factor infertility. Then endometriosis. Genital tuberculosis is actually in fact more in the north of India than the south of India. Having practiced in both the parts, I hardly see any genital tuberculosis in my practice in Chennai. However, in north of India, we used to see so many cases every day of genital TB. And in 50% of the cases, we do not have any risk factors as such. And one ectopic pregnancy is always a risk factor for the next ectopic pregnancy. That means the tubes are damaged. If it's a tubal ectopic, the tubes are usually damaged on the other side also. So, if there is history of one ectopic, the recurrence is 10%, and if there are 2 or more ectopics, the recurrence is as high as 1 in 4 pregnancies, that is 25%. And tubal surgeries, like anything which meddles with the tube, definitely poses a risk for future ectopic pregnancies, that is 2 to 7% risk. So, by cautery, it is slightly higher, like when we recanalize. After ring ligation procedure, slightly lesser, 5 to 11%, and by the classical Pomeroy's techniques, which is used in the cesarean, it is actually much less, that is 6 to 9%. This is, I am telling, after the reconstruction surgeries, recanalization.